Okay, so this is a stillbirth statistics in Europe. And I don't know whether the people at the back can see the x-axis, but this is the different countries across Europe, and UK and Scotland. But you can see that actually the UK and Scotland is one of the highest stillbirths in Europe. In fact, we are higher than other countries like Greece, despite their financial crisis, and Poland. So we're not really doing well in terms of stillbirths, despite all the resources and the guidelines and our protocols and study days. What about actually across the United Kingdom, which might not be United Kingdom in 10 years' time, but so far we are. So England, Wales, and Scotland are almost the same. We have similar stillbirth rate hovering around 5 in 1,000. And that's the case for the last few years. In fact, that's almost the case for the last 10 years. Northern Ireland seem to be doing a bit better. It's interesting to know why. And it's interesting maybe to go and visit them and see whether they're doing anything different to us. But it seems that the stillbirth rate is slightly better in Northern Ireland compared to the rest of the United Kingdom. What about the stillbirth rate compared to other mortality rates? Again, over the last 10 years. So you see the stillbirth rate is the one that's in sort of greenish gray, and it's almost the same, while the neonatal mortality rate is actually better, so it has improved over the last 10 years. And the same applies to the infant mortality rate, has improved. The post-neonatal mortality rate, again, has improved. So our neonatal colleagues have done a good job over the last 10 years compared to us. Well, what are the factors why actually the stillbirth rate, despite all the improvements that we've done, have not really changed much? Well, there are changes in our demographics, are we? There are some public health issues. So we know that the stillbirth rate increases as the mother's age advances. So the older the mother, the higher the risk of stillbirth rate. And we know that actually more and more of women getting pregnant are doing so at older age. So that might be a factor. And why they do that? Because they have career, because they can't find a man, or they don't have money, or whatever. But the other thing, from public health perspective, it's interesting, the slide, so that you see that there are more stillbirth cases in the most deprived areas in England compared to the least deprived areas. So you can argue that if the government is really serious about the initiative of a big reduction of the stillbirth, they should not just invest in healthcare resources and our protocols and management, but also invest in social care and trying to improve the situation for women who live in the least deprived areas, or the most deprived areas in England. If you go on the website, on the NHS Choices, which I did yesterday, and I wrote prevention of stillbirth, you get this, which is very interesting. A very clear message to all women: not all stillbirths can be prevented. I thought this is really nice for them, actually. I thought it's a very nice message. And then they give them a list of advice, like stopping smoking, alcohol, going to their antenatal care, weight reduction of weight, protecting against infection, reporting to the midwives or the healthcare professionals at early stage if there's any concern, and itching because of obstetric cholestasis. So I thought it was actually quite nice advice on the website to women. What are the causes of stillbirth? Well, half of them are unexplained. And if you don't know the cause, it's very difficult to do something about it. Only around 15% are because of congenital abnormalities, around 10% of placental problems, and less than 10% during labor. And Edwin is in the audience. So even with all our improvement in intrapartum care, and we've done markedly well over the last few years, he still would be able to reduce the stillbirth risk by less than 10%, because more than 90% of stillbirth cases occur antenatally. This is a paper that was published last year from the Gardozzi's group, where they conclusion was something very logic. I think most of us would agree, most of us already know that early detection of growth problems can substantially reduce the risk of stillbirth. So if you notice, the baby that you're monitoring because this baby is small is less likely to die compared to the baby that you don't know that is growth restricted and then turn up with stillbirth. So we know that if you know and you monitor, you will be able to reduce the risk of stillbirth in this cohort. But this was a cohort study in the West Midlands between June 2009 and May 2011. And they reported that in this duration, there was a reduction of stillbirth by around half. But that's interesting, but that's not really the best study design to show that an intervention has led to an effect or a benefit, because it's a cohort study. So if I look, for example, here at St. George's, our stillbirth rate in 2005, and let's say it was 10 in 1,000, and in 2011, and it is 5 in 1,000, I say fantastic. So that means I reduced the stillbirth rate by almost a half. And maybe during that time, we introduced a stand. We use a stand to look after these women. So we say, okay, well, stand reduced the stillbirth rate by a half. But actually, during these 5 years, so many things happened. We employed more midwives, we trained the staff, we improved our training to our doctors. So if you look at something in 2005 and 2011, there are many things that could have contributed to the reduction in stillbirth rather than just the stand that we introduced. Yeah? So that's a nice paper, but you just have to appreciate that the interpretation of the results are not that straightforward. Again, this is a graph from the same paper. We showed you the stillbirth rate in all cases, the stillbirth rate in cases when there is no fetal growth restriction, and it's lower. If you look at the group that had fetal growth restriction, we know that their stillbirth risk is higher. But if you divide this group into two, one that we knew, so that was actually detected during the pregnancy, and one that was not detected, of course, the stillbirth rate will be lower in this group compared to this group. Yes? Do you agree with me? Excellent. Have you heard about customized growth charts? So actually, if I have a big baby, so that actually maybe the fetal growth is influenced by the maternal habitus, the maternal ethnicity, and perhaps the parity. So actually the logic behind customized growth charts is actually really good, that we should correct or adjust the fetal growth or the fetal size for the maternal height, maternal weight, the parity, and ethnicity. And in fact, we can use the growth charts not just for plotting ultrasound estimated fetal weight, but also the fundal height, the measurement that we do routinely in antenatal care. But again, it's not really straightforward. It's not that. This is too simplistic view. So the benefit of the customized growth chart is really to differentiate between pathological and constitutional SGA. So perhaps maybe an Asian lady, when she has a small baby, maybe that's not necessarily pathological, because for her, maybe having a small baby is normal. But that is really simplistic. And maybe we have to consider that actually stillbirth rate, we know from very large epidemiological studies, from your everyday practice, the stillbirth risk is higher in certain ethnic groups. We know you're more likely to have a stillbirth rate if you come from a Southeast ethnic background or from Afro-Caribbean ethnic background compared to Caucasian women. So these women are high risk for stillbirth. And it might not be necessarily correct to adjust the fetal size for an Asian woman and assume that this baby is normal for her, knowing that this ethnic group, this woman, is at high risk of having a stillbirth. The other thing is for the rest of them, so parity, again, we said that customized growth charts correct for or adjust for parity. Again, this is data from England and Wales, large epidemiological studies, and it is the stillbirth rate across parity or according to parity. And for those who can see, I don't know if the people at the back can see or not, but the very light blue is nulliparous or first pregnancies. And the darker one is para 1, darker one is para 2, and the very dark one, almost black, is para 3 or more. And you can see the stillbirth rate is higher in the first pregnancy and higher in para 3 or more. So again, is it the correct thing to adjust for parity, knowing that stillbirth risk actually varies according to your parity? In my opinion, no, but we will discuss that. Again, stillbirth according to BMI, so customized growth charts adjust the fetal size according to maternal height and weight. Well, we know that the stillbirth risk increases as your BMI increases. The bigger you are, the higher the risk of stillbirth. So again, it's the same argument. Is it correct to adjust for something that is inherently associated with increased risk of stillbirth? Have you heard about GAP, or the Gross Assessment Protocol? Have you been approached in your hospitals? Okay, hands up for someone who is using it. None in the network. Okay, GAP has not been really introduced across the network, but some of us have heard about it, and I'm gonna hopefully over the next few minutes I will tell you more about it. So GAP is being proposed as a measure to reduce the stillbirth risk in England or in the UK. And in fact, certainly the hospitals in London has been asked to introduce this measure to reduce the risk of stillbirth. So what's actually GAP? Well, GAP is a gross assessment protocol, and it actually has three elements, so three components. The first one is using customized growth charts. The second is online training and competency log, and then an audit. And essentially, it has a measure for the low-risk pregnancies. It promotes the use of customized fundal height. So fundal height, adjusting it for maternal characteristics. And then for the high-risk pregnancies, and this is the risk factors that they use, so obesity, maternal age, parity, smoking, pre-existing diabetes, pre-existing hypertension, antepartum hemorrhage, or history of a small baby or a stillbirth in a previous pregnancy. For these ones, you're supposed to do serial scans. So every 3 weeks, we do ultrasound scan for them. But if you actually apply that, and the West Midlands, again, they did that in their cohort, you found that actually 25% of your population have at least one of these risk factors. A quarter of your population, you will be considered as high-risk group, and you need to offer them a scan every 3 weeks. And the other thing, actually, if you look at the stillbirth cases, you found that only 60% of them had one of these risk factors. That means almost half, 40% of stillbirths did not have any of these risk factors. So if you use this policy, you're really gonna miss almost half of your stillbirth cases. And when they actually looked at this list of the risk factors, they found that they are associated with increased risk of having a small baby or stillbirth. Have you heard about odds ratios? Statistics, too complicated for Saturday afternoon. But odds ratio, to be clinically useful risk factor, you really need to have the odds ratios more than 2 to be really something that, from a public health point of view, something that you should target or consider as a risk factor. And they actually almost, the odds ratios of 2 for small babies. So we know that these risk factors are associated with the risk of having a small baby, but the stillbirth is 1.6. So I'm not entirely certain that these risk factors are really the best risk factors to target to prevent stillbirth. It may be the good risk factors to identify small babies. And I hope by the end of this talk, I convince you that to be gross restricted, you don't have to be very small. So Baski always thinks that he is gross restricted, and I'm not. And he's much bigger than me. So, anyway. But if you actually apply this policy, you'll end up by having to perform 1,100 additional scans per 1,000 births. So for example, St. George's, we have 5,000 deliveries per year. And if you apply this, we need to do more. You need 5,500 additional scans. The other thing that if you do that, you will increase your induction of labor rates, of course. Okay, so this is the risk of risk factors, and in fact, actually, the risk factors that they used were from the RSOG Green Top Guidelines, and this is a figure I showed you before. The 25% that comes from this, the major risk factors is in 20.6% of your population, and 3 or more minor risk factors is 4.9. So that brings to 25%. That's the figure, 25%. How did we get that to? This is actually slides from a group in Leighton Hospital up north, where they actually introduced the use of customized growth charts. and they looked at the impact. So they looked at the change in stillbirth rate, and they looked at the change in the rate of induction of labor, emergency cesarean section, and admission to neonatal unit. And I'm grateful to them because they let me use the slides to show you their findings. So they did a 5-year retrospective analysis, study period between 2009 and 2013. They have 3,000 deliveries per year, and in this analysis they included almost 15,000 deliveries. And what they found is that they did actually have a reduction in the stillbirth after 30 weeks by around quarter, 25%. The induction of labor rate increased from 19% to 32%. There was no difference in the rate of emergency cesarean section or neonatal admission, but they had 50% rise in the number of scans from 29 weeks onwards. But again, this data should be interpreted with a pinch of salt, because this is over from 2009 to 2013. So actually during this period, there might be other things that you've done. You might be improved the training, you improve the staff, you change your protocol. Yeah, so it's not entirely related to the use of customized cross charts. So this is actually data from St. George's. So this is a stillbirth rate over the last almost 15 years, so almost 400 cases or so. And I excluded the cases that had abnormalities or chromosome problems and twins. And this is the stillbirth cases, and this is the birth weight centiles. How you see that more than half of the stillbirth cases, they were not small. The birth weight was above the 10th centile. If you look at the timing of the stillbirth, so this is the timing of the deliveries, you can see the sort of this U-shaped relationship when you actually find that more than half of the stillbirth cases occur at 34 weeks or more, and almost 40% occur at term. So it's consistent with the third where we had it earlier, that a third of the stillbirth cases occur almost near or at term. And if you actually focus on this group, you find that 64% of stillbirth cases are not small. So I'm not sure that targeting small babies or just focusing on identifying small babies would necessarily really reduce the stillbirth rate by more than half. And then I'm going to show you some of the findings that we did in St. George's from our research here. We published this on 11,500 deliveries. When you find, if you look at the Dopplers, the baby's Doppler, which is signs of redistribution, and you look at across birth weight, you find that actually a significant, the lower the baby, the more likely that they have redistribution. Are we all in agreement? Did I lose you?
What's redistribution?
That's something that you see with the fetal Dopplers when you check the fetal Dopplers in the baby's brain in comparison with the umbilical artery. Okay, it's not too complicated, yeah? But you found as well that actually even babies who are not small, so their birth weight above the 10th centile, some of them still have redistribution, which suggests that they have placental dysfunction. Their placenta is not working properly, and maybe they have fetal growth restriction. So it's not necessarily, you don't have to be small to be growth restricted. So we looked at actually the relationship between fetal Dopplers and a series of adverse clinical outcomes, like delivery for fetal compromise. And you see that actually this is something statistical, which is a logistic regression, when you actually look at all the variables and see which one is important. And we see that actually the CPR, which is the fetal Dopplers, is significantly associated with the risk of needing for emergency delivery because the baby is compromised in labor compared to birth weight. So it seems that the fetal Dopplers are more important than actually the baby's size. And the same applies to the neonatal admission. So again, the fetal Doppler seems to be a good measure to predict which babies would need to go to be admitted to the neonatal unit at term. And again, we looked at the morbidity, and that's we're looking at the neonatal deaths, the respiratory distress syndrome, the sepsis, necrotizing enterocolitis, bronchopulmonary dysplasia, all of these parameters. Again, it seems that the fetal Doppler seems to be better indicator than just the fetal size for predicting which babies, which fetuses will have neonatal morbidity at term. And again, stillbirths. So stillbirth rate If you look at the birth weight centile, the baby size, the Dopplers, and the uterine RT Doppler, which we know it's a good predictor of stillbirth, if you actually compare them, the fetal Dopplers is the best. So it's the best predictor of the risk of stillbirth. So based on that, at the team at St. George's in the fetal medicine unit, over the last maybe few months, according to these findings, we believe that actually assessing the fetal Dopplers perhaps is better than just the baby's size, than just simply birth weight, in identifying babies who are at risk, babies who are suffering from placenta insufficiency close to term, and perhaps a better predictor of stillbirth. Another thing, perhaps maybe a policy for reducing the risk of stillbirth is actually predicting women who have increased risk of stillbirth early in pregnancy. And it seems the story reminds me very much of Down syndrome screening. So in the past, we used to say, okay, the older age is a risk for Down syndrome, so everybody above 35 gets Down syndrome. It's a bit like, okay, anybody who's got risk factors have a serial ultrasound scan in the second and third trimester. It's almost like that. It's not sophisticated enough. And over the last few years, Down syndrome screening became so sophisticated that for each woman you have an individualized risk, taking into account everything in your risk factors. Because your risk, my risk if I'm 55 and had an IVF and it's egg donation and I have pre-pregnancy diabetes, my risk is not the same like someone who just have pre-pregnancy diabetes. So really need to be more sophisticated. And in this graph, which is all the red dots are the stillbirth cases, and this is plotted against the centile, where you see that actually before 32 weeks, 70% of stillbirth cases are small. But if you actually look at the stillbirth cases after 32 weeks, only a third of them are small. So just addressing or targeting the smallness is not necessarily going to be the best measure to reduce the stillbirth. So this is, I think, my last slide, and I'm not going to give you a summary, but actually this is more for the discussion, which is a better policy for our network. And my options was that to scan everybody in the third trimester, which some countries in Europe do that. Everybody gets a scan in the third trimester. In fact, some hospitals in the UK do that, offer a scan everybody in the third trimester. If the Birmingham data or Cardozzi's data say that actually identifying the fetal growth restricted babies will reduce the risk of stillbirth, you can argue that scanning everybody is likely to reduce the stillbirth rate because you will identify the small babies. Or maybe scanning only the high-risk women in the third trimester, or whether we should use customized growth charts, or whether we should think of the early prediction of stillbirth, which is a KIBRUS or the Fetal Medicine Foundation approach, or should we just continue with what we're doing? Should we continue with our current practice? And this is open for discussion. So I'm going to stop here. Thank you.